Hello, everybody. Thanks for coming. We were looking out the window, rain, wind, sunshine, rain, wind, thinking, uh-oh, what is anybody going to show up? And so I'm very pleased everyone's here. And we're going to start without Len Nichols, but he will be here shortly, so he'll miss a little bit of my talk, but he knows a lot of this stuff anyway, so I think we're going to be fine. I'm Shannon Brownlee. I'm the acting director of the Health Policy Program here at the New America Foundation, and I'm very pleased to have all of you here. And I think what I'm going to do is introduce speakers as they come up. We have Christine Bechtel from the National Partnership for Women and Families, and then Len Nichols from. I'm suddenly going to forget where Len is from. That's why he's not here. It's a good thing he's not here. George Mason University, excuse me. He's also our former director of the Health Policy Program. So the PEG, as I used to say in the news business when I was at U.S. News and World Report, for this event is an atlas published by the Dartmouth Atlas. And this atlas is called Improving Patient Decision-Making. And we focused on Minnesota, but we also have information about the entire country. And what we really focus on are what Dartmouth has termed preference-sensitive care, which is elective procedures. And what we did is we looked at variation in rates of 10 different procedures around the country, surgical procedures around the country, and looked in the Medicare population, because those are the data that Dartmouth has been using. So I'd like to walk through some of the findings and then talk about the policy implications. This being Washington, we need to think about policy. Let's see if I know how to run my own machine. I do. So preference sensitive means it's elective. It means that somebody's preference drives whether or not the patient gets the procedure or the test or the drug. And when something is elective, it means that there are trade-offs. It means that there's no one answer for how you should be treated. So an example of a non-elective would be you're in the hospital, you're having a heart attack, you need to be reperfused. Your arteries need to be opened up, either with drugs or with a procedure like an angioplasty or a stent. So an elective surgery, elective test, example would be bypass surgery is an elective procedure. It's used to relieve symptoms for the most part. It may have some mortality benefit for some people. An elective test, one of the ones that we looked at was the PSA test, the prostate-specific antigen test. The men in the room over the age of 50 know what this is. And it's used to screen men for prostate cancer before they show symptoms. This is an elective test. You don't have to have it. And there are trade-offs to not having it or deciding that you want to have it. So that's what elective means. It always involves trade-offs. And one of the things that we think is going on is that it is provider opinion. It is the provider's preference that often drives which treatment is used for any given patient. And it turns out that providers, physicians, nurses, physician's assistants, surgeons, have different opinions about what procedure is best for many situations. One physician will think if you're having stable angina, you're having chest pain from heart disease. One physician will think that it's a good idea, always a good idea, to do angioplasty and stents, and another will think that it's better to try medical management first. But the fact is that there are trade-offs between each of them, and it should be the patient who's engaged in that decision. And finally, we think that the decision should be based on the patient's preferences, not on the physician's preferences, as much as sharing the decision, and the patient's preferences have to be engaged. That's why it's called elective. So that's not coming through, is it? Well, you don't see the colors, but about 25% of Medicare spending is these preference-sensitive conditions. I think it's about 15 elective surgeries account for about 25% of Medicare spending. So the bulk of Medicare spending is for other kinds of conditions, mostly chronic disease, and it's the routine hospitalizations and tests and drugs and procedures that go along with chronic illness. But about 25% is these preference-sensitive elective surgeries for the most part. And these are examples of preference-sensitive conditions. We had a couple of others in there. I think we have a couple of others in the atlas. But silent gallstones, you may not know what those are. This means that you have gallstones that have been discovered when looking for something else, usually. So you were getting an abdominal CT scan for something else, and the gallstones showed up. They're called silent because they don't cause symptoms. So the question is, do you need to do surgery on somebody who has gallstones but no symptoms, or can you just kind of wait and see what happens? Some physicians will recommend surgery right away in the worry that you will have a gallbladder attack that could lead to severe complications, and then you'd have to have an emergency surgery, while others would say you can wait. Joint arthritis, replacement of the hip or knee versus pain medication versus exercise versus losing weight. So these are the kinds of decisions that patients face and physicians face when patients have these conditions. And I was kind of joking that being middle-aged male is the indication for a PSA test. Not a disease. So how many people have seen a map like this before? So mostly everybody. Oh, I'm preaching the converted then. So this map is of the 306 hospital referral regions. This is a standard that Dartmouth has been using for the last 20 years. And what a hospital referral region is it draws a line around the zip code, the home zip code of Medicare beneficiaries who get most of their care from community hospitals within that region and from a referral hospital within that region. So there are 306 of them, and in many ways you can think of them as a true healthcare market because the consumer, the patients, are getting most of their care within that market. So there are usually multiple hospitals, multiple community hospitals in a region, and one or more referral hospitals, often a large academic medical center. So what this map shows is the rate, the number per 1,000 mastectomies among women. Oh no, that's wrong. I screwed up. This is the prostatectomy one. This is the number of men who get a prostatectomy. It's prostate removal, surgical prostate removal for prostate cancer in each of these referral regions. Sorry. And the best headline of the news stories that have appeared after this atlas was published in the last couple of days was supposed to be the amazing case of the disappearing prostates in San Luis Obispo County. Because California, San Luis Obispo, which is, I believe, is this thing going to work here? Sorry about this. Laser? No. Isn't San Luis down here? Somebody from California? Anyway, it's bright red. And it's the dark red, and the rate in San Luis Obispo is 3.8 per 1,000 male beneficiaries, and the lowest rate was in Albany, Georgia, was 0.3. So there's a 7-fold difference between the lowest rate and the highest rate. Now, some people might say, well, that's because there's a lot more prostate cancer in San Luis Obispo, and that's probably not what's going on, not a 7-fold rate. Certainly we have variation in rates of cancer in the country. We've seen variation in rates of breast cancer, for example. But if we, I think I might have skipped a slide. Yes, I did. So this is the rate of mastectomy in the hospital referral regions, and it goes from a high of 2.6 per 1,000 female Medicare beneficiaries down to a low of 0.3. So we know that there are some, quote, hotspots for breast cancer around the country. But once again, we're looking at a, 8-fold difference here. So it is very difficult to explain this kind of variation on the basis of illness, on the basis of patients having different rates of illness in different parts of the country. And if you look at these smaller maps up at the top, let's see if I can point one out. Here's San Francisco. So this is the San Francisco Bay, and you can see there's considerable variation in the rates of mastectomy in these different regions around San Francisco Bay. And the one of them is yellow, which is the lowest rate, and that's actually Napa County, which is supposed to be one of the high rates of breast cancer in the country, one of the hot spots for breast cancer. So we see these kinds of variations for pretty much every one of these elective surgeries. Here's radical prostatectomy again. Here is coronary artery bypass grafting or bypass surgery, heart bypass surgery, and it goes from a low of 1.8 to a high of 9.0, and it's all over the map. I mean, it's an enormous range. Let me see if I can give you the high is McAllen, Texas. We all know the name McAllen if we've been reading the New Yorker. McAllen is the highest spending region for Medicare spending in the country. It's way down at the southern tip of Texas. And the low is in Pueblo, Colorado, 1.9. So McAllen is 8.9 and Pueblo is 1.9. And the average for the entire U.S. for bypass surgery is 4.6. And this is just another way of expressing the exact same thing. Each of those dots represents the rate in one of the 306 regions. So you can see way at the top, 9.0, that dot way at the top is McAllen, Texas. The dot way at the bottom is Pueblo. And this report focused on Minnesota. So the 5 dots right in the middle, kind of running in a line right in the middle, are the 5 regions of Minnesota. So you can see that Minnesota is just sort of right in the middle in terms of its rates of bypass surgery. And this is simply showing that the variation, even when you look at smaller geographic areas, you still get this enormous variation. So this is the hospital service areas within Minnesota. There are, oh gosh, I'm going to forget how many service areas there are in Minnesota. But you can see that it ranges once again from 1.9 to 6.9 for the rate of bypass surgery in each of these HSAs. And you can have adjacent HSAs. An HSA generally includes maybe 1 to 3 community hospitals, smaller hospitals usually. You can see that adjacent rates can have very high HSAs can have very high rates and very low rates.
Excuse me.
Yes. Oh, I don't. Mayo's actually pretty low in a lot of the surgeries, but it's not as low as you might think. It's actually fairly high, I believe, in back surgery, but don't quote me on that. So what's going on here? Why are we seeing this kind of extraordinary variation in surgical in rates of surgery? One thing that's going on, we know, is that provider opinion varies tremendously. Physicians differ in their opinions about what works best for a given patient. And one of the reasons that their opinion may vary is if there's not very good evidence for so if there's not really strong evidence for the benefit of one procedure versus another procedure, or if there simply isn't good evidence to give them odds about who's going to benefit and who isn't going to benefit. So for example, there was poor evidence around tonsillectomy, for example. Those of us who were over the age of, I think, about 40 probably had our tonsils out. When we were kids, everybody had their tonsils out, but there really was no evidence for why you had your tonsils out. So one physician would say, well, those tonsils are really inflamed and they ought to come out because it'll prevent you from getting strep throat. And another physician would say, you haven't had strep throat yet, why are we going to bother taking out your tonsils? So the evidence wasn't there, and there was tremendous variation in rates of tonsillectomy in different parts of the country. And you could get huge differences in rates of tonsillectomy in adjoining towns, depending on what the physicians in one town thought versus the physicians in another town. So poor evidence is sometimes the problem, and in other times there's lots and lots of evidence and there's still differences of opinion. This becomes sort of a cultural difference. There are practice patterns that build up over time within single practices, for example. So the highest rate of angioplasty and stenting is in Elyria, Ohio, and it's really 1 or 2 practices in this town. It's not a very big town. It's about 30 miles from Cleveland, which is the home to the famous heart hospital, the Cleveland Clinic. And the rate in Elyria is significantly higher for angioplasty and stenting than it is for Cleveland. And the reason is that there is a large cardiology practice there that simply thinks that stenting and angioplasty is a good thing. Now, that may be changing. It may have changed because there was a big story about this in the New York Times, and the cardiologist said, well, we better start looking at what we're doing. We had no idea that our rate was quite as high as it is compared to others. So lack of consensus can be a tremendous driver. Now, just because there's consensus doesn't necessarily mean that there's really good evidence. So, for example, for hernia repair, the consensus in the United States, at least, has been that you do surgery. If a man has a hernia, whether or not it's symptomatic, you do surgery. Now, but there wasn't really any good evidence for the reason that the surgery was being done. And it was being done a lot, and I'd like Dr. Ma to comment on this. It was done largely because of the worry of strangulation, that the bowel would get out of the hernia and get cut off, circulation would get cut off. Studies have now been done that show that the rate of strangulation is actually pretty low. So the reason to do the hernia operation ought to be whether or not it's symptomatic. The preventive theory may not be a good enough reason to do a surgery. Now, is that your sense of where the literature is right now?
That's absolutely right.
Good, I'm not screwing up. Good.
Completely. What we've actually shown is that the risks of operating, risk of anesthesia, risk of complications of bleeding, actually outweigh the very tiny risks of strangulation.
So if you're not symptomatic, if you're not having pain, not having discomfort, then there's not really any reason to do it.
Exactly.
Right. So there was this consensus before, but it was based on there wasn't evidence, but there was consensus, and now there's evidence. Now is there consensus?
No. We don't accept the new.
Right. And so it turns out who you see is what you get. And I don't think patients are completely aware of this fact. I think patients overestimate benefit, for one thing. They often overestimate how much of what their physician recommends to them is really based on good evidence. And there is also a lack of fully informed patients. We know this from many, many studies that patients are really not very well informed. There's a concept of informed consent. Has everybody heard of? Everybody knows informed consent, right? But the informed part is often missing. We know that patients don't understand what the trade-offs are a lot of the time. We know that they consent without knowing what those trade-offs are. They overestimate benefit and they underestimate risk. So, and they are not sharing the decision with their physician a lot of the time. They're delegating this decision. Doctor, what would you do? If it was your mother, what would you do? Doctor knows best. And physicians are not formally trained in eliciting what it is patients really want. So we have a mismatch here, and physicians often think that their patient has the same values that they do. So if the physician values, say, avoiding uncertainty about something, they will assume that the patient feels the same way, but the patient may have a very, very different take on things. So we have this lack of communication, we have this lack of information, and that's one of the things that we think is reflected in this variation data. And I want to tell you a story about what this really means to patients. There's a breast cancer surgeon, some of you may have heard this story directly from Dale Vidal herself. She's a breast reconstructive surgeon at Dartmouth Hitchcock. And she tells this story about a patient who went through a process that they do at Dartmouth called shared decision-making. So the patient has early-stage breast cancer, and she has two choices. She can get a mastectomy or she can get a lumpectomy with radiation. And the outcome in terms of her risk of dying of her breast cancer are exactly the same. But obviously mastectomy and lumpectomy have very different effects on her as a woman. So she went through this process where she was able to look at a patient decision aid. And this is a little brochure that lays out what the pros and cons are of each choice. It actually has a little video that shows women who chose mastectomy versus women who chose lumpectomy. And then it had a questionnaire at the end that asked her what she valued. And it turns out that women who really value their breasts tend to want to get lumpectomy. I mean, this makes sense. And women who value being certain, more certain that they will not have a local recurrence of their cancer, are going to choose mastectomy. So she indicated that she wanted a mastectomy. And so she went to Dr. Vidal and said, I've made my decision, I want a mastectomy and I want to talk about reconstruction. But when Dale looked at her questionnaire, it turned out that this woman valued her breasts very highly, and she thought there's something wrong. The two are not matching up. You made it. Glad to see you. The two are not matching up. And so she said, you need to go back and do the shared decision making again. So the woman went back, she went through the questionnaire again, and then she came back about a week later to Dr. Vidal, and she said, you know what, I really wanted a lumpectomy. The reason I chose mastectomy is because I thought my surgeon wanted me to do that. So these kinds of choices have enormous consequences for patients, and delegating decisions like this is really, really probably not in the best interests of patients. It's not patient-centered care. So what I want to show you now is a little short film of a woman that I interviewed in upstate New York recently, and she's 42 years old. She's an immigrant from Brazil. She came when she was 18 years old to go to college in the United States. She fell in love, had 3 kids, and she was in the process of going to school to get her nursing degree, and she had a big test ahead of her. Her oldest son was going away to college, which was very traumatic, very tense time, and her husband was abusing her. So she had a really tough home life, and she was having panic attacks. Her heart was racing, she was feeling faint, she was completely freaking out, and she went to the emergency room. She was worked up at least twice in the emergency room. They found no heart problems. You know, they were worried that maybe she was having a heart attack. And she was sent home. She then went to her primary care doctor and was sent to a cardiologist. And the cardiologist did a stress test, which is a common test to look at whether or not you do exercise, and then your heart is measured to see if you have any kind of heart disease. Absolutely clear. No evidence of heart disease. There is a problem where some stress tests come out negative, but the patient actually does have heart disease. But this woman had, her only symptom was she had tachycardia. She had a very high rate of her heart rate was very high. So she went to the emergency room once again and was sent once again to the cardiologist. And the cardiologist said, just to be sure, let's do a catheterization. So this means that she's lightly sedated, and she has a little tube run up through a blood vessel in her abdomen up into the arteries of her heart. Dye is injected to be able to see the arteries of the heart, to see if they're clear. And so she consents, and she goes ahead and has the catheterization, and the doctor says, you're clean as a whistle, you have absolutely no heart disease. And as he's pulling the catheter out, he perforates her artery. And it perforates 3 times. And she has to be defibrillated 9 times, which means you're basically dead 9 times. And she said to me, you know, they say that you see a light when you die. No, it's really dark. You only see the light when you come back to life. And now she really does have heart disease. She was not a fully informed patient. So let's do the film. Can I do this? No.
I was worried because, I was after 40, and usually a woman can have, what they call the silent heart attack and stuff like that. And I start there might be something in my heart. And I say, maybe I should do the test. And I asked the doctor, and they were like, insist, no, you have to do the test. You have to do the test. If you do this procedure, we would know for sure. Okay, and I thought it was a really necessary procedure. He didn't give me other answer except just you have to do a catheterization. There was no other option for me. And I thought it was a simple, like he said, it was 20 minutes. You cut it off, you put a camera, you see how your heart is done. Didn't think it was a major deal. Everybody, before do any procedure, even a simple, even blood test, I think you should do a lot of study before, because it can go wrong, and there's always complication after, and it will take a chunk of your life if something go wrong, like it happened with me, and then you never be the same. Tired all the time, I short of breath all the time. If I go do simple things like mop a floor, put my head down, I have no air, goes up, I have to get up and put my head up. I can't run the way I used to run. It's just not the same person. It's like a 43-year-old and a 78-year body or something. Just not the same. I feel older, very old. I only had to take Tylenol before, and now I take 9 medications just to get going with my heart, and just for one specific thing. And it's just hard, very hard. I never had the discussion with the doctors. What would be other options? What are alternative tests you could do? That's what I would do. Or maybe I would take the time and say, I'm just going through a lot of stress right now. I'm going to do on my own because I just don't trust anymore. Well, there's one specific day that was so overwhelmed day, and I just couldn't breathe. I couldn't breathe, and my heart was racing. I'm like, I'm having a heart attack, and I have pain on my chest, and there was no way. My son called the ambulance, and they took me to the hospital, and then they did EKG, all the tests, and like, well, everything looks normal. Just think you're going through a lot of stress, but just follow up with your doctor. And you follow up with your doctor, and the doctor say, well, your blood pressure is high today. Let's follow up with a cardiologist. And that's how it happened. One doctor to another, and then you go. But see, everybody, this is my body. I know my body. You just a person that know what could be wrong with me. But who really know the symptoms, how I feel, is the patient. And that's why the doctor should always take good advice from the patient, say how you really feel. What's really your symptoms? Not the doctor say, oh, I think you have this. But I can come to you, like I was saying, I'm under a lot of stress. And I keep and give the clues. I'm under a lot of stress. I'm having almost panic attack. I'm going to anxiety. I'm giving you the clues. And just take that, and if they have, explore them more in that time, and forget about the others option that I could have. I think I will not have to go to this procedure if they just believe me when I say I'm just going through a lot under stress. If they just listen to the patient more, and remember the patient knows their body more than the doctor. Because we can feel, they can look at, but we can feel inside our body. We know our body better. He had to listen to me more, because every time I went to visit him, I say the same thing. I'm under a lot of stress. And if he had to listen that word, under a lot of stress will cause a lot of stuff. And if we were better communication, if he had to really listen to me, I didn't have to go to that procedure. I still get mad just to talk about it. I'm mad. I'm really mad. But I'm mad with myself, too. I think I'm more mad with myself because, was become a nurse assistant. I should know better. I should have, but then I was so under a lot of stress that I just want to get over with. If the doctor told me jump out of the bridge, I would be jumped at you. It has to be the person in control of your body and say, you're just here to guide me a little bit, but I would take the right or the left, and I would do the stop sign. Pretty much just, you would be my GPS, but I'm driving my car.
So, as you can see, this the failure of a patient to be fully informed has had really serious consequences for this woman. And who knows whether the procedure was actually necessary or not. There is some doubt about whether or not she should have had this procedure, but the fact is that surgery is a serious event. Even a 20-minute catheterization is a serious event, and even if these kinds of perforations are really quite rare, which they are, it happens to somebody, and patients need to know that it's a possibility. So the implications here are, we're talking about invasive procedures. Major surgery is a major event for patients. And I think it's easy for us to sort of forget that as physicians, as policymakers, that it seems so matter of course. It happens all the time that people undergo procedures that you forget what it really means to the individual patient. There is a potential for wrong patient error here, and I think we may want to start thinking about error in a slightly different way. So if it's an error to operate on the wrong Mr. Smith, to do a knee surgery on the wrong Mr. Smith in the hospital, is it also possibly an error to do a surgery on a Mr. Smith who, if he had really understood his trade-offs, would have chosen a different option? And then we have the ethics of giving patients elective tests, elective procedures, elective drugs, without making sure that they're fully informed and without sharing the decision. So there are a number of issues here that we can think about and we can talk about. And there is a different way of doing things. I told you a little bit about it. This is Dartmouth. This is actually the breast cancer shared decision-making process. Dartmouth uses commercially made patient decision aids, and this woman is with a health coach right now, the woman on the right, and they're going through the decision aid and looking at what the options are and what the risks and benefits are of the various options. And these commercial decision aids, they are part of what should be the main goal, which is that we have really patient-centered care, and one of the means to getting there is ensuring that patients are fully informed and that they can share that decision with their physician. So what fully informed patients need to know is, number one, the decision is theirs. And it's astonishing how often patients don't understand that an elective decision really involves them, that they really do need to be engaged in the decision. And there are always going to be some patients who don't want to be involved in the decision and they're going to delegate it, and that's okay. But many, many patients find that they really do want to be involved once they're given an opportunity to really understand the material at their own level. They need to understand that there's no free lunch in medicine, that there's nothing that doesn't have some kind of trade-off. That if you decide to do nothing about your cancer, there is going to be a trade-off there. If you decide to do something about your cancer, there's a trade-off there as well. There may be risks there as well. And that their values really matter in the decision. And that's the piece that I think is absolutely crucial and is sometimes hard for all of us to kind of wrap our minds around, that what patients care about really does matter. There isn't a right answer in an elective situation. We also know some interesting things from looking at randomized controlled trials of decision aids versus usual care. Now, this is a Cochrane review. Annette O'Connor is the first author. And what the Cochrane review does is it's a systematic review looking at all of the randomized controlled trials involving decision aids and shared decision making. And what these randomized trials did is they took a group of patients and they randomly assigned half of them to get usual care, to be informed usually by their physician about what the possibilities were. And the other half got to go through a process where they looked at a patient decision aid and they shared the decision with their physician. And there are now, I think, over 70 of these randomized controlled trials at the time of this paper. I think there were something like 52 of them. But what's interesting about the trials is that they show very clearly that patients often make very different decisions when they have the opportunity to be fully informed. So to sum up the results of all of these trials, patients were more engaged when they had a chance to look at a patient decision aid. They decided that the decision really was something that they wanted to have a part in. They were less unhappy with the decision they made, lower decisional conflict. So they didn't get to the end of the surgery and have regrets about having made the decision to do it. Or they didn't get to the end of not doing the surgery and have regrets about that decision. They were more informed. They just basically understood the trade-offs better and what was going on, and they made decisions that were more based in their own values. And finally, this is the policy bonus, possible bonus. Overall, there was about a 20% drop in demand for elective surgeries. So some patients changed their minds after going through patient decision aid and saying, I want the surgery, and some decided that they didn't want the surgery. But on balance, there was about a 20% drop. So there are a number of patient decision aids that are out there, and this starts getting into what the real policy issues are now, in part because of legislation, because of the ACA. So there's HealthWise is a fairly large company that produces decision aids, and then Health Dialogue is another company that produces decision aids. And these decision aids do a number of things, but this is the prostate cancer PSA test decision aid that Health Dialogue makes, and this is just showing you one of the ways that it expresses things like risk It expresses the same thing in multiple ways. Some people read risk better. Some people need to see it. And so what this is saying is the number of men who will be diagnosed. If you have a room full of 100 men, 17 will be diagnosed with prostate cancer, and 3 of them will die of prostate cancer. And that's true now, and that was true before PSA testing. So the rate of death from PSA testing is about the same as it was 25 years ago. So the policy issues here are we don't have very many producers of AIDS right now, and they are, for the most part, very conscientious about producing balanced aids that don't push patients towards one direction or the other. But will a Medtronic's decision aid for implantable heart defibrillators be as balanced? This is one of the things that we need to think about is who's going to start producing decision aids, and are they going to have a commercial interest in what the aid pushes patients to do? There are other policy implications. We need more decision aids, certainly, and it's very time-consuming and expensive process to do the literature review to really produce a balanced aid. Who should pay for the aids? Right now, insurers pay for the aids for the most part, and employers do. Should the federal government be in the business of producing decision aids? How do we certify decision aids? How do we say these are good ones, these are not good ones? Do we grade them, A, B, and C? How do we pay physicians to do the process of shared decision making? And should patients be given a break in things like copays if they engage in shared decision making? Should we promote that? There are also legislative issues. So far, Washington State is the only state to pass legislation that promotes shared decision making. They also passed. They also have increased legal protection for physicians who engage in this. And we can talk about how this may be very, very important to tort reform, that we rethink the sort of the standard notions of what tort reform means on the basis of implementing shared decision making. And the Affordable Care Act has provisions for developing, certifying, producing, disseminating patient decision aids and shared decision making, but there's no money behind it. And finally, there are 17 states that are considering legislation similar to Washington states, including Minnesota, which is one of the reasons that we focused on Minnesota. But let's look at what the cost implications are. So this is a look at the hospital referral regions in Florida. And you can see that there's quite a bit of variation for the rate. This is the ratio of knee replacement to the U.S. average. And you can see that Fort Myers is 1.75 times the average, the U.S. average, whereas Miami, right next door to the right in the yellow, is about 0.41. So there's tremendous variation within a fairly small geographic region. But what does that mean in terms of money? So the U.S. average for spending is $3,500,000 on hip and knee replacement for Medicare recipients. If we were doing the Miami, if everybody practiced the way the doctors practice in Miami, we'd save more than $1 billion a year. If everybody practiced the way physicians in Fort Myers practice, and the rate of knee replacement and hip replacement was the same as it is in Fort Myers all over the country, we'd spend another $1.2 billion. So there are real cost implications for how the effect that shared decision making has. And what's difficult to know is the Miami rate too low? Is the Fort Myers rate too high? We don't really know what the right rate is because we don't have shared decision making. We don't have patients making the decisions on the basis of being fully informed. So I just want to sum up what the bottom line is for the 3 Ps, physicians, payers, and patients. Better decision quality for patients, better care, greater satisfaction for patients, and that's a good thing for physicians as well, and probably for payers in the end. And for payers, the demand for elective surgeries and tests may go down when patients are making fully informed decisions. So with that, thank you. That was a lot of data to go through, and I'd like Len and Christine to come up. And I'm going to ask you both to talk about your own work a little bit. Just spend a couple of minutes to talk about what you do. But I wanted to say welcome Len back into the fold. Len is our former director. Yes. And then we'll open for questions. So, Christine, if you'd like to start, that would be great.
So I'm Christine Bechtel, and I'm the Vice President of the National Partnership for Women and Families. We're a nonprofit consumer organization based here in Washington, D.C. We've been around for 40 years. This will be our 40th birthday in June. Time to get a PSA test soon.
Mammogram. No, not mammogram. The U.S. Preventive Services Task Force says don't.
Yes, exactly. So we do a lot of work in healthcare, but also in work and family policy, workplace discrimination, family medical leave. Most people know us as the organization that wrote the first draft of the Family and Medical Leave Act. But we came to understand through that debate the real importance that healthcare plays in the lives of women and families, both as in terms of their economic security, but also for women in terms of their role as caregiver, and also just the fact that they use more healthcare services than men. So we started to get involved in the healthcare policy arena about 20 years ago, and while we do a lot of work around insurance market reforms, et cetera, by far our primary focus has been on the delivery system and looking at ways that we can reorient the system to make it more patient-centered. And we have the privilege of leading a number of coalitions of consumer organizations who work with us in trying to achieve that work. Some of you are in the room. I know Mark Gorman and Steve Finley are here. So I want to start by saying congratulations to the authors who are really making a terrific contribution to the national debate around how to make our healthcare system work better for patients and for families and for providers. I think the report makes some really important strides in achieving the triple aim of healthcare, right? So better health outcomes, at least as patients define them, better population health, and clearly lower costs. The report for us really calls attention to variations in care, but does so in a very patient-centered way, as you heard Shannon describe, in really addressing some of these variations that frankly result in outcomes that patients aren't always happy with, and we know that we can do better on. And the report really suggests some very concrete steps that we can take to advance patient engagement and patient-centered care more broadly. I think it's worth mentioning that a lot of people define patient engagement and patient-centered care in different ways. Often when I talk to people, I get the sense it's sort of like the Supreme Court's definition of pornography. You know it when you see it. And I think we can do better than that. So fortunately for us, the Institute of Medicine did define it. I'm guessing that all of you are familiar with that definition, but at the risk of being annoying, I'm going to read it because it is absolutely relevant to the content of this report. So the IOM defines patient-centered care as care that is respectful of and responsive to individual patient preferences, needs, and values, and it ensures that patient values guide all clinical decisions. So to get there really requires redefining relationships in healthcare. About 18 months ago, we undertook some research with patients and families directly to understand what they mean by patient-centered care, what that would mean to them, what the kind of care that they would value in the healthcare system, and also to test their reactions to some different options, including shared decision-making, for changing the delivery system. So I'd like to articulate the 4 key things that patients told us that they want from the healthcare system. We did a series of focus groups and a national survey, and then we also convened a series of meetings with consumer advocates who work with patients every day. So what they told us was that the first thing that they wanted was whole person care. They were really tired of being looked at as a collection of diseases and body parts. They wanted to be understood in a broader context. I think Marilda did a fabulous job of talking about that. She said over and over again, if the physician had just listened to me and understood what else was going on in my life. And it is this notion of me as a whole person with a whole set of life circumstances and needs and values and preferences beyond just what is happening in my physical disease state that patients really want to see. They want clinicians to take the time to really get to know them in that context and to understand the full range of factors that's going to impact their ability to get and stay well. And that's how they want to get to treatment recommendations that align with their preferences. The second thing that they articulated was communication and coordination, and those are really the biggest pain points for consumers in the healthcare system. They just want their doctors to talk to each other. It is that simple. And when we think about the context of this report and preference-sensitive care, it really shouldn't ever be just a physician, or, a specialist or a primary care provider. It should be a team of people providing care. And consumers really want their team to talk to each other. And they really understand at a fundamental level that communication is not just a nicety, that when their doctors are not talking to each other, that is really what can lead to misdiagnoses, errors, and in particular waste in the healthcare system. So definitely not a trivial notion. The third thing that they talked about was patient support and empowerment. And this is where they talked mostly about partnership with clinicians and really having a stronger voice in choosing their treatment options, in developing their care plans, in choosing care team members as well. They also wanted support for self-management, in other words, meaning their ability to manage their own conditions to get and stay well, what some people have called patient activation or self-efficacy. And then finally, ready access to care. Pretty self-evident, but essentially right care, right time, right place, all as patients define that. And that's different for every patient. So to get to this kind of patient-centered care and more shared decision-making that's called for in this fabulous report, we've got to shift our paradigm. But shifting that paradigm, I think, requires addressing a number of myths that we currently hold in the healthcare system. And the report does a phenomenal job of pointing to research that dispels those myths, but I want to call them out head on. So the first myth is what patients say they want is nice and it's important, but doctors just don't have time to figure that out. And what really matters is clinical outcomes. So what we know, though, is what patients say that they want, which is care that's reflective of their needs and preferences and capacities, is directly related to better health outcomes, better population health, lower costs. Again, the triple aim. And in fact, engaging patients around their values and beliefs is what gets us there. The second myth is patients always want everything. They want the newest drug, the newest test, the latest treatment. And what we know is that when patients are in a trusting relationship with their physician and when they're given all of the information on benefits, on risks, on options, and they're able to participate in shared decision making, they actually often make more conservative treatment choices than we would have otherwise guessed. And there's some great research in the report that tells us that. And further, when patients are really comfortable that the physician knows them, again, as a whole person, they're much more confident in the treatment recommendations that the clinician makes. So it's not as simple as just giving patients whatever they want. Third myth, doctors know what patients want, so they don't have to ask. And what we know is that what patients want is information on all of their options. The report, again, has some really great research that found big differences between what doctors understood or believed that patients wanted and what patients actually said was important to them when they were making treatment decisions. So we can assume that clinicians know. And I want to say that clinicians have the best of intentions, but we're struggling to come out of what I would characterize as a fairly paternalistic system. And I think we've made huge strides forward in that regard, but we're not there yet. So we can't assume we know. We have to collaborate. We have to ask. So the final myth that I wanted to talk about is the if we build it, they will come myth, which is the notion that if we just build the system the right way, patients will embrace it. I think we have some good experience in the HMO debate that tells us otherwise, where we experienced quite a consumer backlash, and actually that makes sense for why we see among some patients a real fear and scarcity mentality when we think about the context of physicians as gatekeepers in the HMO experience. So I think that's part of what created the myth that patients want everything. But the damage that I think was done in that debate did not destroy patients' desire for a trusted and a caring relationship with their clinician. And shared decision making is one of the best strategies for helping to reinforce and strengthen that relationship. That experience, though, did really heighten the need for patients to be involved in designing new approaches to care, like shared decision making, or new models of care, medical homes, ACOs, or whatever the term du jour may be. And the concept here is pretty simple. If we engage patients in actually designing how we're going to move a ball forward, they can not only be helpful in ensuring its success, but it's the way that we know that they might actually embrace it. So back to our research for a moment, we explored a number of delivery system solutions or strategies with consumers. In particular, we explored health IT, the medical home, quality measurement and public reporting. We explored shared decision making and payment reform. The top two in that list were health IT and the patient-centered medical home, because they really were viewed as strategies that responded to the challenges that consumers face today in coordination and communication that I talked about. In shared decision making, though, it was interesting because what they told us was, yes, I want a stronger voice in treatment decision making. There's no doubt about it. I want to have a stronger voice, but I don't really view that as a strategy for improving the delivery system. I view it as a fundamental right. And that was so clear in all of our research. They've really viewed this as a right. They were like, how is this a new special thing? This is my right. So they do know, though, that physicians are pressed for time. They absolutely get that. They do embrace team-based care. They do understand and are open to the idea that it doesn't always have to be the physician that is talking with them. And so I think it's likely that as we think about new strategies for integrating shared decision-making into the care process, if we engage patients in the design of those new strategies, they're definitely going to be more likely to embrace that, whether those strategies are leveraging technology, the meaningful use of health IT, and other strategies. Or I'll say that Frank Opelka is a surgeon in Louisiana. He's working with the charity hospital system down there to do a really cool thing, which is to create a shared decision-making department in the hospital so that he can refer a patient for consult down to that department. I think it's brilliant, and I think patients would love it. They're a valuable resource for new ideas. So to wrap up, shared decision-making is definitely something consumers and consumer advocates view as a fundamental right in the healthcare system, but we also think it's really a win-win. It's obviously a win-win for patients who will be more satisfied with their decisions and are more likely to have better health outcomes as a result. We think it's a win for clinicians because it's part of how we can begin to address this belief that more care is better. And we think it also will support stronger relationships between patients and clinicians, which we know that clinicians want. And if we think it's going to improve health outcomes, take a look at the provisions of ACA, which are beginning to hold physicians accountable more and more for health outcomes. So it's a good strategy for helping physicians succeed in that respect. And there's some evidence that it could actually reduce malpractice claims. So that's something we want to continue to monitor. And then finally, this system, clearly wins by addressing these variations in care that Shannon so articulately described, by decreasing costs and improving not only outcomes, but experiences. So I look forward to Len's comments and for a great discussion.
Thanks, Christine.
Well, thanks, Shannon and Christine. It's a privilege to be back here. It's a real pleasure also, and I will start by apologizing for the one thing I need now. George Mason clearly is a better scheduler. I do have it on my thing at 4 o'clock, but anyway. So I'm glad to be here. I think Shannon wanted me to start with kind of what we're doing, what I'm doing now, and I'll just say I'm still motivated by the same things. I think it's a moral question about whether we figure out how to get everybody to have access to our healthcare table of plenty, and I think it's a economic question of how to make sure that's affordable both for people, families, and for governments. And that means fundamentally, I'll just say it bluntly, we're going to have to pay the Chinese back, and that's a pretty important motivating factor because it's real. So what I've been doing lately is actually, believe it or not, helping the Commonwealth of Virginia. It's a Commonwealth, not a state. You may not have known that. Make a sort of a pretty good run at planning the implementation of health reform, which was fascinating and also appears to be somewhat successful. They're moving forward down there, and I live there, so I'm happy to see that happen. even though on the one hand they're challenging the lawsuit, on the other hand we're building an exchange, so we're bipolar. That's good, yeah. But unmedicated, so we're doing fine. So it's
the medications
definitely
can
shared
work.
decision making, no question about that. Then the second big project is working with a number of people around the country, developing a monitoring strategy for how to essentially measure and evaluate states' implementation of health reform going forward. And that's kind of exciting because there's a tremendous amount of work being done in metrics, as you both know quite well, because you're doing a lot of it. But then my true passion, and what I think is the most important thing I try to spend as much time on as possible, is trying to be a catalyst for multi-payer payment reform. To be blunt about it, as exciting as all the stuff in PPACA is, if we don't figure out how to get this beyond the public programs, it's not really going to transform care. It's not going to work. So what I've been doing is trying to, proper words probably, seduce employers, health plans, clinicians, and then consumers in communities. I mean, I won't belabor the politics. You know they're toxic. My observation is real communities where people live are the only places where you can get away from the politics, because every human being wants to make their system work where they live and work. And so the idea is to assemble kind of a metaphor of a table and to get people in a room and say, okay, what do we really want to achieve here? And when you do it that way, everybody wants a triple aim. They want low per capita costs. They want good patient experience. They want fundamentally a sound quality. But how do you do that? And obviously it's going to depend on kind of where you are. Well, that's really what's exciting to me about the shared decision-making apparatus, because, I mean, I've known Shannon for a while. I guess I probably met you my very first time in the old building. And I'll just say I've always thought for Shannon, the shared decision-making stuff is really a moral question. It really comes down to what we ought to do to make sure patients have full informed choice. But obviously, the economist in me sees the economic implications of this. But I would even go on to say the more important ones, particularly at this moment in our political discourse, are the social and political implications of applying this. Because, let's be frank, we got to pay the Chinese back. But it's really hard to do that when every time you talk about anything that has to do with reducing cost, and it is labeled rationing of some form. And that, you might have noticed this, is wildly effective, and therefore it's repeatedly used. And so what you've got here is a situation where one side, if you will, in fact one corner of one side, constantly tries to talk about it as gently and humanely as possible, and then as soon as it makes any traction, the other side screams and calls it things. So the way I think about it is really we've got two big choices here. It is kind of like two roads diverge in the yellow wood. We're going to pay the Chinese back one way or the other. We could just cut stuff. We could just say we're going to reduce the Medicare benefit package by a third, which is roughly what Paul Ryan's plan would do. We're going to turn Medicaid into a block grant. And we're going to have high deductibles for everybody else, and those of us who have great jobs will be okay, and the rest of the country, well, we'll read about them. So it's really, that's one path. The other path is to try to do what, in my view, the reform bill tries to do, imperfectly, but nevertheless it's a path down the road of combining information and incentives. And I won't belabor incentives, but I want to focus on information, because it is information that actually gives us the power to truly create the opportunity. We're not there yet. The opportunity for patient-centered care. And in my opinion, it is that demonstration of the potential of patient-centered care that makes it possible for us to construct an antidote to the rationing rhetoric that is so greatly holding us back as we go forward. So what I want is about 60 Meraldas, is that her name?
Marilda.
Marilda, on YouTube. And because what it
She'll
comes
be
down
there
to,
soon.
okay,
At a
'cause
YouTube
what,
near you.
what it comes down to is figuring out a way to demonstrate that what, quote, the reformers, unquote, have in mind is indeed patient-centered. And it's got to be way beyond what I would call the traditional metrics, which most of us have spent most of our lives refining, developing, arguing about, and getting papers published about. My metaphor here is my brothers, and some of you know them maybe, but they are fine Americans. They are not burdened with the education God gave me, so they see life far more clearly, and they really don't care about HEDIS scores and, NCQA and all this bullshit. They want to know, did they leave me naked in a room for a long time? Did they tell me what I should have done when I left? And did it hurt? And if it hurt, did they warn me? I mean, these things matter to them. So fundamentally, it is about making them feel like, in fact, what we're doing with this information incentive stuff is giving the clinician tools to make it more patient-centered. Now, I will say one last thing about the clinician culture. It's kind of interesting, and I'll just say that model of the doc who's developing a shared decision-making apparatus in a hospital is a wonderful model. It is not going to be unanimous among the clinicians in our country anytime soon, because the autonomy thing's a big thing. And let me just say, every single human being, I would say, in the healthcare system, from anybody who sells anything to anybody, is pretty scared right now, because all business models seem to be under threat, under attack, if you will. And so you're going to have to figure out a way, I think, to incentivize physicians to kind of learn how. I think of CE credits and stuff like that. Let's kind of link some of that stuff, because they're not stupid people. They've never made a bee. They have elephantine memories, and they don't ever pee. So fundamentally, they can do a lot of stuff really fast. But you got to put the requirements and/or incentives in place for that to happen. And I submit to you, some people are not going to adapt well to that, and they're going to just not do it. But then the new generation, they're all doing this stuff anyway, are probably much more equipped to do it. It will require a different set of skills. Think about it. What we admire at some level about these trauma surgeons, they don't mess around. They just come in and cut here and gone. And that day of that clinician being the superhero may be passing to some degree, because there's not a lot of informed consent. And that's, anyway, let me stop and we'll take questions.
Diane Meyer had RSVP. Diane, are you here? Well, I'd hoped Diane would talk about the fact that we need shared decision-making for end-of-life questions as well, and we haven't gotten to that point. We don't, there are a few patient decision aids out there, but not very many for end-of-life questions. Yes, Sherry.
Hi, thank you so much. This is such an interesting report, and I really appreciated all the comments you guys made. I just wanted to throw out two questions. One is, to what extent is the problem with informed consent of patients a problem of informed doctors? Their ability to keep up with the latest research and knowing what what the costs and benefits might be of a particular procedure, perhaps that's part of the problem. So perhaps some of the decision aids would, just a question, I guess, is that part of it? And the second is, I really worry about these decision aids and who's going to make them and what's behind them, and I'm just curious how, that seems to me like the hugest obstacle to this, and just like to hear you talk more about that.
I'd love a physician in the room to talk about the how hard it is to keep up with the material and how you present it. The other piece of it is, how do you present it to patients? Because how you understand it as a physician and how you need to present it to a patient are often very, very different things. Caroline, yeah. No, yeah. If you wanted to answer that question, and then we want to.
Okay, the answer is it's very difficult, and what I'm a primary care physician and an attorney. The way we try to keep up now is electronic services like UpToDate. I thought that's what decision support was supposed to be, but apparently it's to make sure that we don't do stupid things or expensive things. What I want to say about the panel is shared decision making is the law right now. There's a reason why patients feel they have a right to it. It's because that's what's supposed to be happening. In the end, the decision is supposed to be the patient's. So why doesn't it happen? One thing, to a man with a hammer, every problem looks like a nail. The more procedural physicians we have, the more they will see their procedures as useful and helpful. The other reason is time. We do not get paid for time. A shared decision-making process takes time. Some people are probably very happy with a health coach and a computer. A lot of other people, particularly when you're talking about something that's dangerous, they want to talk to the physician, and they want to talk to a physician who knows all about them. and whom they trust. Well, that takes time. And at $75 for 15 minutes, that's a level 3. There are 5 levels. If you want a level 4, it takes a half an hour, 2 patients an hour. In the real world, you cannot survive with that. We need to pay less for procedures so we have fewer procedural lists, and we need to pay more for cognitive services. Not primary care, cognitive services, talking to and listening to the patient. The reason doctors jump in after 18 seconds in a typical appointment is because they have to see 20 to 30 patients a day to make a living.
I'm going to ask my co-panelists to respond
Amen.
to both the question and comment.
I just said amen.
Okay,
Yeah,
okay.
I mean, obviously you're dead on, and the 30 patients a day, no question about it, and that's what I mean by incentives have to fundamentally be revamped to make this all feasible. I would like to address the second question, which is who makes these things and so forth, and what can policy do about that and so forth. And I think what I saw in the Cochrane thing, although I must admit I have not read it, but I depend on you to tell me this, was evaluations that have been done of the existing aids. And you think about it, that picture Shannon had of the Dartmouth conversation between the patient and the coach. Seems to me part of the game is not just the aid itself, but who's doing the, shall we say, educating. And that's part of the evaluation process. So in effect, what a decision aid should be thought of as is a medical device. And the same kinds of criteria that would be applied to any other new medical device should be applied here. Under what conditions does it work? And the conditions could be incredibly elaborate to specify, but really important to test when you test them.
Just to elaborate a little bit there, it is kind of a two-step process. You have to be able to look. We have to be able to certify the aids to start, to say that these are balanced aids, that the information in them is accurate, that they present information in a way that patients can understand. The second piece is validation or certification or training or whatever of the actual process of the health coach and the physician, and that's a much larger enterprise even than the production and the certification of the aids. And I think CME, continuing medical education for how you share decisions, how you coach patients, is going to be crucial. And who pays for that is another question.
So I do want to say before we go on to another question, which is I think often in the health policy conversations that we have here in Washington, it goes almost immediately, but always ultimately back to the dollar. And I get that, and there are very understandable reasons. But I also think it would be a mistake to walk out of this room thinking, well, we can't get shared decision-making more widespread right now until we change the payment system, because I think we can. And I think it comes back to the point that I made about really engaging patients and figuring out the solution. When we've talked to patients, they go, look, my neighbor's a retired nurse or physician or whatever, and, they would love to put their knowledge and skills at work. Why can't we, use them and enlist that, or staff Franco Pelka's shared decision-making department with retired, clinicians, whatever. I think there are some creative ways that we could work with patients to understand the role of the whole care team and how we can move this process forward, even in today's framework, because there are just such huge benefits, not just to patients, but to clinicians and to the healthcare system in the form of lower costs, that we've got to figure out a way to do it even in the current construct.
I'm letting Sam make the rounds with the mic, so he'll see
Hi,
you up in
I'm
front.
wondering if you looked at financial interests of providers at all in shared decision making. For instance, if should patients be made aware of if a provider has a financial interest in some sort of treatment facility? Say a urologist has a financial interest in a testing facility. Should the patient be made aware of that fact and take that into account when weighing what sort of testing and treatment they are provided with?
Christine?
Well, I didn't write the report, so I can't speak for what the report
Oh, we didn't
looked
talk
at.
about that in the report,
Okay.
no.
But, there are anti-kickback laws that do limit that to a degree. But it is back to the question that I think Shannon maybe raised earlier about how do you validate the independence of decision aids, for example. But, there's always a risk in that regard.
We also have there's a sunshine provision, I believe, in the ACA that talks about disclosure of financial relationships. So that will help, but I don't think the decision aid is the place to do that, to disclose
some of the
that.
specialty societies are grappling with this issue pretty seriously right
Yeah.
now.
There's exceptions to this anti-kickback.
Yes.
Right.
Yes.
Right.
Especially when it comes to testing.
Yeah.
So that's in addition to.
Right.
Yep.
Please.
Bob Rosenblatt, National Academy of Social Insurance. I'd like to ask each of you to explain how the findings would result in policy. For example, the Cochrane Review shows that when patients are informed, elective surgery drops 20% and health outcomes are the same, which is obviously a preferred result. Are you confident enough of that to go to Secretary Sebelius and say, elective surgery can be cut 20%. We think you should look at the outliers, the red things, and inform doctors and hospitals in those regions that effective in 2013, they must do 20% less elective surgery because we're not going to pay for it anymore. Would you do that as a public policy recommendation?
I wouldn't, and here's the reason. When you see an outlier at either end, what we don't know, because we don't have fully informed patient choice and shared decision making implemented, we don't know whether the low end represents undertreatment or the high end represents overtreatment. We don't know if the national average represents just the right rate. So I don't think that that's the way to implement the policy. I think the way to use this from a policy perspective is to push for the shared decision making and the fully informed choice. And there are a number of ways that the federal government can do that. One of them would be to start purchasing patient decision aids. That's sort of an obvious one. I don't know that it's necessarily the best one. Another way would be to start requiring that physicians do shared decision making. I'm not sure that's the best way, because there is a certain amount of provider resistance right now. So it's not clear exactly how it should be pushed, but I can say that one of the ways that it can be encouraged is to start looking at tort reform with an eye towards shared decision making. Physicians who engage in shared decision making and can document that they are engaging in shared decision making should be protected from lawsuits from patients who then turn around later and have decisional regret, for example. And there is a very famous case in physician circles called the Merenstein case, where a young physician and his practice was sued after the physician, after he did shared decision making, very carefully documented, with a patient over PSA testing. The patient decided not to get the PSA test. He went to another doctor, got it without his knowledge, and it turned out he had advanced prostate cancer. And he turned around, or his family turned around and sued the practice for not saying you have to have a PSA test. Physicians who engage in really well-documented shared decision-making should be protected. And that may, in fact, help speed the process of getting it into the culture. I also think that continuing medical education ought to be part of that as well. But part of the problem there is that the majority of our physicians' continuing medical education is paid for by the device and drug manufacturers. So it should be paid for by somebody else who wants to promote shared decision making.
I would definitely support the link to malpractice. I think that's the key to every physician's heart, and I definitely think that one of the big flaws in the reform bill is that it didn't really address it in a serious way, and it couldn't, and all kinds of reasons we can argue about that in the bar, but it didn't, and therefore it's a huge issue, and I definitely support everything Shannon just said about that. The other tool I would add to the mix is professional societies. If you look at the cardiologists, whatever else may be true about how often they do this stuff, they've got appropriate use criteria. Now, they're not perfect and yada yada, but they say among their own colleagues with their own criteria worked out by their own committees, 20% of what's done, this is their number, 20% of what's done in lots of specific cases, they're not just across the board, but the specific cases they've studied, is not called for, is fundamentally not justified by the presentation of the patient. So that kind of, I would say, peer-to-peer, if you will, discipline can be used in lots of different ways. And I think that's got to be a tool in the toolbox, in the toolkit. I would never say to the Secretary of HHS that we should just start paying at 0.8 times what we paid last year. What I would say is that, you know what, you're way out of line here from what we can tell. Your own society thinks you're doing too much stuff. So what we're going to say is, prove it. Let's talk about it. And then maybe you start a conversation and find out they are all above average in Minnesota. But anyway.
So I don't disagree with what my colleagues have said. I would probably add a couple to the list. I think the most easy is, do you create a CPT code for shared decision making and start actually paying physicians on it? It's a question. You got to look at unintended consequences, of course. The other is quality measurement strategies, right? So there are some measures of decision quality that are pretty close to ready for prime time. That would be very interesting to build into public reporting and pay-for-performance programs, whether they're public or private or both. I would say also patient experience surveys. These are the CAP surveys, the clinician consumer assessment of healthcare providers surveys. And CAP surveys do ask questions of patients about whether they felt like they had all the information they need, whether they felt that they were part of the decision-making process. I think we can probably strengthen some questions that the CAP surveys ask. But what would be very interesting would be then to publicly report the results so that when consumers go to choose a provider, they can see what other patients are saying about how well the provider really engages and provides information. I would say also it's worth looking at the meaningful use of health IT, the public debate right now around how federal incentives will be paid to providers to adopt technology. In the first stage of that program, hospitals and physicians, or actually, I'm sorry, it's just physicians in the first phase, but eligible physicians would have to deliver self-management resources electronically. In other words, use their electronic health record to identify contextually what kind of self-management support that particular patient might need based on their disease or condition, and then deliver that electronically. So I don't see a reason why we couldn't at least create the capability to deliver decision aids, again, once we have enough decision aids that are also validated and tested, et cetera. And then the final thing that I think is important is generally increasing the availability of decision aids for different topics, whether that's through federal grants or even federal employees, who many of them are physicians, and the VA and DOD and others, bringing together sort of the best minds to really look at and create new decision aids, because generations are increasingly going online for health information. It is not just the doctor's role to promote shared decision making. The patient absolutely has not only a responsibility but an interest. Mm-hmm. And so I think the more we can disseminate decision aids and modules, the more empowered patients will be from the get-go.
And I'm waiting for the day when a hospital advertises in a big banner, instead of having their Da Vinci surgical robot or their new CT scanner or whatever it happens to be, they say, we have shared decision making. We make sure you get the care you really want, the care you need and the care you want. But it hasn't happened yet.
Hi. I know Christina had mentioned something about retired nurses, having them be an option for sharing these decision-making tools with patients. And I was just wondering if there's been much discussion about having non-medical professionals help patients go through these decision-making. I know that we spoke with, out of Puget Sound, I believe they're called Group Health. It's an employers group, and they actually have a program where they have their clients call ahead, and they go through these decision support tools with somebody from the insurance company. And that's how they've found a way to include shared decision making, even if the doctors don't have the time or the money to do it. So I was just wondering what your opinion was on, anywhere from a nurse or a nurse or somebody who's still clinical down to somebody more like a patient navigator or health educator, and how they might be utilized in this shared decision making process.
Just to clarify, those health coaches those are health dialogue aids that are being used by Group Health, and those health coaches are nurses. They're all trained. Yes, they are. they're it's a call center and all that, which is a fairly effective way to do it. I think a more effective way is to actually have the person right there and have each physician practice have a health coach of some sort who has some training. But you do have to have some real training to be able to do a good job of this.
Well, and I had to be able to Skype with them too, right?
Yeah.
Really be able to use some online technologies. I mean, I think the point that you're making is valid, which is we need to think broadly about the kinds of people that are qualified to do this. And I would have said health educator. I would have, considered them a healthcare professional, although not, a physician necessarily or a nurse, although some of them are. So I think it absolutely needs to be somebody with a healthcare background. But I think, again, if we engage patients in thinking through who do they trust, who do they want to listen to, what kind of information do they need in order to go back to the physician and really, or the nurse, and be prepared for a conversation and have thought through and articulated their values and preferences, that's going to get us, I think, probably 80 or 90% of the way, because it is that articulation of what's important to me, what outcomes really matter for me, that I think we forget to stop and check with ourselves about, and that it makes us more willing to sort of go with whatever the doctor recommends because whatever, and we trust physicians, which we absolutely do. So I think it's worth thinking broadly with patients about the kinds of trusted resources that they need.
Can I respond really quick? Thanks. I'm just thinking about how much work that we do working with patients and with disease-specific advocacy organizations, American Cancer Society, et cetera. And
who is
you
we?
did have,
who are you? Could you identify
I'm sorry.
yourself?
I'm with the National Partnership
of
Women and
okay.
Families. I work for with the Aligning Forces for Quality Project, the Robert Wood Johnson Foundation Project. And I think that, if you're looking at, for example, a specific decision tool that's made for a specific disease, for example, arthritis or, different, if those particular societies were to train people just in that particular decision tool, that there might be an option for somebody with with a healthcare background, absolutely, but a non-medical background who might be available and trusted by their community as they are advocates for them on a regular basis.
Well, as the Cretan economist on the panel, I will certainly hasten to support the proposition that you don't want to say only one profession can do this. A few years ago, we did a study from New America of a physician practice, big one, in Northern California, Hill Physician Group, and they have it's like 3,000 docs in total in this IPA, and they're mostly in little bitty practices, so they're not necessarily, they weren't when they started electronically wired, all that stuff. And through concatenation of events, including building up electronic infrastructure, they now compete on a very successful level with Kaiser and everybody else. And part of what they do is they put what they call coaches into physician practices, and the coaches spend a lot of time with the diabetics, et cetera. And yeah, they have to be trained, but I can assure you they much more recruit on the personality and sort of, are you the kind of human being that another human being would trust? Then you make sure that you put the right stuff in their head, but then you turn them loose. So they got ex-coaches and all kinds of stuff doing this. So it's really, I think, I definitely agree they got to be standards on what they're taught. They got to be certified somehow. But I would hope it could be wide open because it's really about that patient trust.
And then ultimately, the patient goes to the physician or the PA, and it's with the knowledge that they've gotten, and says, "Okay, this is what I'm thinking I really want to do," and they talk about it.
There's a hand back there. Sam.
Oh no, sorry. Go ahead, John.
Thanks. I think it's been a wonderful panel. I just wanted to share some insights as a practicing surgeon that I think would help with the next steps. They say it's 10 years from being a novice to an expert to being a novice once again. And what we see in medicine, most surgeons evolve to the point where you pretty much perform 3 procedures in practice. If you're a transplant surgeon, liver, kidney, pancreas. I'm a general surgeon, so gallbladder, hernia, small bowel. In cardiac surgery, heart valve, cabbage. And so what transpires is, as a practicing physician, you feel the need to protect turf. And you really seek to protect a very valuable resource, which is operating room block time as a surgeon. And just like the opportunity to speak on the Senate floor having the opportunity to schedule operations on the preferred 7:30 starts on Monday, Tuesday, Wednesday go to the more senior established surgeons and the ones who generate the most money and are the busiest. So I agree completely that financial conflicts of interest should be disclosed, but there are a number of other conflicts of interest within hospitals, within physicians' minds that aren't being discussed sufficiently with patients. You know, if you don't use all your block time, you'll lose it. And so in the back of your mind as a surgeon, you know, if it's not entirely clear with the patient right in front of you, you may be inclined to recommend surgery. The thing that really bothered me the most was when surgeons and hospitals really started to aggressively advertise for patients, because I really felt that that should not be necessary. And I would finish by stating that I think it's very encouraging that shared decision-making could reduce the amount of elective surgery, but because our nation is currently experiencing a crisis in access to emergency care. And I work at a hospital with about 30 operating rooms. And every day at 7 a.m., Monday through Friday, all the operating rooms are filled with completely elective procedures. And all of the patients who've been admitted overnight or come in during the day, they get put on the waiting list. And, you know, they get done in the middle of the night and things of that nature. Mm-hmm. And what we have done across America is we have incentivized the delivery of elective care over where society's needs are the greatest, which is in the emergency population. And I haven't quite yet seen the study. Maybe someone will do it. I don't think that the unnecessary incidence of emergency and trauma care is that high. I don't think that most people at 2 or 3 in the morning are going to, you know, perform a procedure that a patient doesn't really need. So I just wanted to share some thoughts from a hospital and physician's perspective.
I want to tell you a little story that I didn't understand until just now. I was following the chief of emergency medicine at a major hospital in Baltimore, and a woman came in with a compound fracture of her ankle, bone sticking out of the skin, terrible pain. And the head of the emergency department, they were wrestling to try to get her pain under control. It was very hard to figure out the right dose of morphine. She's screaming. It's pandemonium. And he turns to me and he says, "Now you watch. Surgery, orthopedics won't take her." And sure enough, he gets on he has his resident get on the phone, and it's a resident up in orthopedics, and they're saying, "We don't have any beds." So he gets on the phone with the orthopedics resident and says, "You have to take this patient and you have to take her now." And the resident in orthopedics says, "Okay, we'll take her, we'll do the surgery, but you have to have her post-op down in the emergency room." And this emergency room was overflowing with patients on gurneys, in the hallways. It was an incredibly unsafe place. And he said, "No, I'm not going to take this patient. You have to find a bed." And they found a bed. They grumbled about it, but they found a bed. And I thought, how is it that this huge hospital doesn't have a bed for a woman with a broken ankle? And now I know why.
I think we need a YouTube video on hospital scheduling. I want to know. I mean, this is like news to me, and I'm completely mortified, you know? And I think patients would be likewise.
Well, this is part of the
totally
business
mortified.
model revamp we got to do.
Good luck.
Yeah.
You have
Good
about
point.
2,500 institutions that are going to fight it.
Dave Oxter, Research Institute for Independent Living. My question is, what is the role of the clinical practice guidelines in decision making? And the reason I asked that question, and this is from personal reference, I was had a high PSA, went to a urologist, and I was following health care in 1993, and clinical practice guidelines, they're a big thing. They had a book out, and I looked at the book, and I happened to get the author of the book. So, you know, I went to him, and I read the book, and he did the book, you know, and so there wasn't much related to decision making. I mean, it was all ready-made for you. I mean, we were both in agreement, and so, you know, I'm just wondering, you know, how about the clinical practice guidelines? I mean, they're researched and everything, and they were published then. And then the other thing that happened to me was I got referred to biopsy, and I had prostate cancer. And they referred me to the physician, and I says, well, when can I get a prostatectomy? He says, you don't get one. He says, after 70, we don't give them. We just give you one dose of radiation and that's it. And that was 10 years ago, and I'm happy with both decisions. Clinical practice guidelines, where do they fit in? The research that says this is what we should do.
Clinical practice guidelines are consensus guidelines. They are based on the best available evidence, and the thing that is not so transparent to, I think, an awful lot of people is that often the evidence doesn't exist. The crucial clinical trials haven't been done yet, and so the clinical practice guidelines in some cases are based on an enormous amount of evidence, and in other cases are based on a best guess. And they change quite a bit. Yes?
Can I just add to that before we go on? I think to your question, clinical practice guidelines play a huge role, and they're what decision aids are based on. But sometimes you have more than one option, and so the decision aid is really about helping you understand the benefits and risks of one option versus another, rather than just taking my doctor's word for it when I've got two options. How do I really begin to explore benefits and risks which are based on clinical guidelines? And I think that's important. That's a big part of what gives patients some real trust and faith in science. So.
But another thing to say about clinical guidelines is they're based on averages, or they're based on a bell curve, and they don't look at everybody.
True.
They look at what's the best result for most people, 2 standard deviations on either side. Your patient in the picture who had the cat that caused so much trouble, well, she was a woman. Women don't always present the same way as men. She almost certainly didn't have cardiac disease, but if she had not had the cat and had the heart disease, and she could have, it's a small group, but they do exist. She would have brought a lawsuit, just like the guy with the PSA, just like a woman who comes in at 25 and wants a mammogram. Well, if the incidence of breast cancer for 25-year-old women is very low, but it isn't zero. And you will face in court, you will end up, if you do enough procedures or you don't do enough procedures, you will end up with the person in court who was the outlier.
I think you just made the argument for shared decision-making for elective procedures and tests just now, which is that the patient needs to understand what the trade-offs are on either side of the decision. So in the case of, we were just talking about hernia repair, patients need to understand that if you decide to do the surgery because you're more worried about strangulation, you risk the risks of surgery. You face the risks of surgery. If you don't do the surgery, you face the risks of strangulation, which are low. And on both sides, the risks are low. And so it's a reasonable decision for a patient. Either side is a reasonable decision for the patient. So clinical guidelines are just that, they're guidelines. There aren't, I don't know, I mean, is there any sort of estimate of, I know the estimate for how much we spend on evidence-based care, but I don't know if there's a really good estimate for how many things in medicine are sure things. Like, don't take arsenic. Don't give your patient too much Coumadin.
This is another question about bell curves. In your survey work, where you worked with focus groups and the like, what kind of distribution? You said that the average result was that patients wanted to be more involved. What were your outliers in terms of patients who didn't want to be more involved, in terms of patients who really wanted to be more involved in decision making? Did it look like a bell curve, or did you have strong tails?
Christine, I think that's yours.
So we did a national survey and focus group, so I don't think that we could map a bell curve on that. But I will say that what we heard was that 2 things. One is that most patients absolutely wanted to have a stronger voice. And sometimes that voice meant making a decision to trust their physician and just go with what he or she says, but that they still wanted to have that decision be their decision. So the population of patients that we talked to were patients with multiple chronic conditions and their caregivers. And our theory was if you can make this work for them, you can make it work for anybody. And so these were patients who sometimes were more complex than others, and they were older as well. They were mostly older patients, and but we still saw, I think that there are a number of older patients who will want to trust their doctor, but we saw the vast majority of patients and their caregivers really wanting to have an active role. 1,500, and we did 8 focus groups, including 2 in Spanish. We didn't ask the questions that way. I can follow up with you offline, but these were questions that I said were designed to figure out how to talk to patients about options in the delivery system. What do you think of Health IT, and how do I explain that to you, and why do you like it? So it's a little bit different in that regard. But when we explored shared decision making specifically, particularly in the focus groups, because obviously you can get a lot more anecdotal information, even older patients in those contexts really felt that was a right. But it doesn't mean that it's what every patient wants.
This has been a very interesting conversation to listen to. I want to come back to a word that Len mentioned just in passing, which is autonomy. And he was talking specifically about the physicians' collective sense of how powerfully they cling to their idea of physician autonomy. And that's a big part of what the problem here is. And I think shared decision making is the wedge of the patients trying to claim some of the autonomy back for themselves in the dyad between the physicians and the patients. I mean, that clearly is what your video is talking about. I mean, I remember when you showed that video a couple of weeks ago at the Foundation for Medical Decision Making's forum. Some of the doctors in the room, I think, were a little bit taken aback by, because there was a question about this. Wait a minute. She said she's the driver, and the physician's only the GPS.
Right.
Is that? And the question was, is that going too far? Well, now I'm not, as a patient and a patient advocate, I don't think that is going too far. But so Len, you think a lot and creatively about the political culture and political values in the United States. And we're seeing daily now for a month the awakening of a desire for autonomy and political autonomy and participation at the political, in a way that was unimaginable even 3 months ago. How much value from a policy perspective would the idea of having individual patients in this country come to think of their role as a more democratic participant in their care outside of the heated debates in legislatures?
Wow, it was very well put, except the part where you expect me to have the answer. But I really like the way you put it there, and I've been thinking the very same thing. Literally in the cab, I was on the hill. That's why I was late. And so here's my response for what it's worth. Essentially, we gave physicians this pedestal place by ceding to them the idea that they were all knowing and we would do what they said. My mother would never question. She would have jumped off the house or whatever if a doc had said do it, even though I'm pretty sure he probably wasn't the best one in the history of civilization. But nevertheless, he was the one in our town, and so we all trusted him growing up. Well, we have begun to challenge authority across the board. Hell, it's going on in Cairo and Tunisia. So it probably is, Jefferson said, a healthy thing every now and again. The trick, it seems to me, is how do you get back to the evidence base? yes, you want the consumer to ultimately make the choice, but Shannon's been very clear, and Christine certainly lives it every day. It's all about informed choice. Well, who gets to decide what is information? And the only thing that makes me nervous about saying this is all wonderful is how do you know for sure when the patient understands a requisite amount? You know, I've been at different times in my life and am again a teacher. And I will tell you, not every student makes an A. And sometimes the B student actually understands it pretty well and just sort of screwed up, whatever. But, you know, human family is large and diverse. And how you judge whether a patient is sufficiently informed, that seems to me to be an incredibly subtle psychological thing. And so all I can think of is, in a way, and the focus groups may help us here, you're sufficiently informed if the patient feels like they're sufficiently informed. My mother felt like she was sufficiently informed. Dr. Petty was going to make the decision. You know, I can't forget. Marilda is pretty sure. So it's going to be subjective, at least until we get far better at calibrating. But I would completely agree with the symmetry here, and that all elites are being challenged, and we're being challenged. And you know, at the end of the day, the responsibility is on the elite to be far more transparent. To me, the key word in all of the last year and a half is transparency. What the bill tries to do is enforce transparency on insurers for the first time ever. In my opinion, if we do indeed implement it, and there's still a big if about that, then that transparency will necessarily spread to hospitals first, because that's where the biggest pot of money is, and to doctors, because they're actually running the show, both in and outside the hospital. And then we might get to a place where we have more objective criteria by which to judge this business of are we properly informed. But in the short run, I think it is subjective.
I'm going to add to that, if
Good.
I might.
Yes, please do.
So I think it's, you know, I always love you, but I think it's not that simple.
Well, good.
And I think that we can't look at shared decision making in a vacuum. I think if you think about whether a clinician, for example, understands, in Marilda's case, the whole person that she is, right? What's going on in her life? Is she being abused? I mean, her level of being informed is almost irrelevant unless you understand what else is going on, because the physician can't possibly be making informed treatment recommendations except based on science if he or she doesn't understand what's really happening in the full context of this person's life and in their health and health care. Not right. So we as patients, we encounter the healthcare system, but then we live our health in like the rest of our lives, right? In our work life, in our home life. It's a part of our whole life. But somehow when we end up in a hospital or an institution, there's almost this perception, or not perception, but our lens is so institutional and so therefore limited. So I think it's not as simple as, is there an opportunity for shared decision making, and is the patient well informed enough, and who judges that? I think it's an important question. But I think at the end of the day, if we don't reorient the system to be more oriented around patients than it is around providers and payers, we're never going to get there, and it's not going to matter in some respect. Shared decision making will help, absolutely, but it isn't going to get us all the way there unless we're really looking at whole person care. And I think to that point, because this is not we're not creating a healthcare system from the ground up anew right now, right? We're having to reshift, reorient, push our current healthcare system. Then yeah, I think clinicians do have a responsibility to embrace and be responsible for changing a culture that has been historically paternalistic. Patients have a responsibility too, to be active participants in that, there is no doubt. But I think it is a good thing for clinicians to be responsible for making sure that patients get, hey, this is your decision. So I'm here as your GPS. I couldn't agree more. And I went to medical school, right? So, you're relying on me, and in fact, you're paying me to be that guide for you. But this is your body, this is your decision. So, you know, here are the resources that are helpful to you in exploring that decision, and let's work in a partnership together. But that requires, I think, a number of other inputs that have to happen as well.
I think, Mark, you know this, but the one of the fathers of shared decision making is Jack Winberg, and he calls this the democratization of the doctor-patient relationship. So what I want to know is whether you're advocating that patients start gathering in the squares. So I think let's wrap this up. Thank you so much, all of you, for your terrific questions. Thank you to my panelists. You guys were great. This is an issue that's going to keep bubbling up and bubbling up and bubbling up. So thanks a lot for coming.
Thank you.
Nicely done.